let's turn to the question of preoperative versus postoperative therapy. We have trials that are positive, at least for significant improvements in disease-free survival, and FDA approvals for immunotherapy and EGFR inhibitor therapy with Tagrisso post-operatively. Estella, you mentioned previously that your center participated in this important and I really think provocative trial. Checkmate 816 gave 3 cycles of chemotherapy with or without Opdivo immunotherapy. And the results showed a marked improvement in tumor shrinkage. And when they looked under the microscope, 10 times as many patients had no evidence of disease viable under the microscope after the treatment, compared to, it was only 2% or 2% and change versus over 20% between chemo with or without the Opdivo. But we don't have an FDA approval for this. And in some ways, these are conflicting, competing platforms, ideas. So where do you see preoperative versus postoperative fitting in? You know, how competitive are they, would you say?
So, you know, these trials, preoperative and postoperative, they're very selective. So in the Checkmate 816, we were only able to enroll 2 patients because you had to have all these restaging. You had to be a patient that could have waited that time for the whole workup to proceed with surgery. In the trial, they did start, they did have, most patients had surgery within 6 weeks of finishing those 3 cycles of chemo or chemo IO, but there were some delays. And I know that's one of the concerns. Like if you do preoperative therapy for a patient that you could possibly take them straight to surgery, who are you delaying? So I don't think, and I think you can tell in the trial, a lot of investigators didn't feel enthused to enroll patients with stage 1B, which was included more than 4 centimeters, or stage 2. That really this is something that we clinically would favor for someone who's more high risk. But I think that 1 out of 4 patients having a pathologic complete response rate must translate into something. Are you going to get that benefit if you add immunotherapy post-op? We don't really know because we don't have survival data for any of these trials. Right. And that's what we need to be able to tell us, you know, it's better to start early, you'll do better surgeries, or you'll get better outcomes. And we don't know that yet. I will say that patients tolerated that very well. There were actually more patients that finished the chemo component of this trial than the chemo IO. So like, correction, there were more patients that finished chemo IO than chemo alone. So I don't know why that happened, because you would think if you have IO, you have more side effects, but it was well tolerated. That was our experience. It was well tolerated. Although I'm sure if you do a very larger study, you will find patients that have horrible complications from immunotherapy and they never got to surgery. So the trials is only, it was a trial of 300 and so people. So we don't know,
right?
You don't know enough.
There weren't a lot of those patients who stumbled on the way. I mean, that's always a concern, is you can lose patients from complications or progression before they get to surgery. But there's also the real risk of patients who go straight to surgery and are either unable or totally uninterested in anything after the surgery. And so there's really a question of, if your goal is to give the total package of whole body therapy and local therapy like surgery, are you more likely to get through by starting with the systemic and then, having more people motivated for surgery than losing people after going through surgery and saying, I'm not doing a thing after this?